So I want to introduce Goodarz Danaei. I've been practicing his name, who I met in a recent visit to Boston. Goodarz has an interesting background. He got his medical degree at Tehran University, and from there went to Harvard in a Master of Science program and a Doctor of Science program, which he got in 2010, working with Majid Azadi's group at the Harvard School of Public Health. Some of you may have seen the three-part series that was in the Lancet. This is the February 11th issue of the Lancet. There are the lead three articles are from Majid's group, and one of them, the senior author, is Goodarz, and focusing very much on the global burden of disease, particularly in cardiovascular disease, which he's been very much involved in through his master's and doctoral program. We invited him here to take a good look at us and get a sense of all that we're doing. He's now in his postdoctoral year and thinking about where he might join a faculty. So I was delighted he would come and speak with us about his work, which is obviously from the global health standpoint extremely important in setting priorities. And in that same issue of the Lancet, there's a very nice editorial, and of course I'm in a building where a lot of people do cardiovascular disease. But it says the title is "Stemming the Global Tsunami of Cardiovascular Disease," and it's a really call to arms by the Lancet to based in this particular case on the three papers that were in the Lancet that week for doing something about this huge problem. I was in a meeting yesterday, a conference yesterday, quite interestingly, on another part of campus, just to show you how long it takes to get people to appreciate the global burden of cardiovascular disease. I was in of all places, cultural anthropology, where there was a candidate, it was a job talk for a candidate for someone in position we have there. It was a joint position we're looking for candidates who do global health and cultural anthropology. And this person chose to talk on his research in India on global obesity. And there were three of the members of the faculty, our faculty, from Cultural Anthro, who raised their hand and said, "Why on earth are you studying this?" We thought people interested in global health and cultural anthropology studied poverty and malnutrition and AIDS and malaria and things like this. And I found myself in a funny position where I had to take the floor on behalf of the candidate and say, no, this is really a global problem, and I think it just shows you how far we still have to go, not in this building, but not far away from here, to make people realize what a huge burden this is. And what's coming is really going to be a tsunami. So I want to introduce Goodarz and welcome to Duke, and particularly to the Clinical Research Institute. Does he use this?
No, I have.
You have a mic yourself? Okay, good.
I think. Can you hear me, Bill? Yep. Good afternoon. Thank you so much for coming here. Thank you, Professor Merson, for your kind introduction. It's a great honor and pleasure to be here at Duke University, which has had a great influence on our understanding of prevention and treatment of cardiovascular disease. I'm going to talk about research I've been doing in the last couple of years on individual and population level effects of multiple chronic disease risk factors and their interventions. The reason that I've chosen this topic is that I think one of the major successes of public health and clinical medicine in the last few decades that has been less appreciated sometimes by the media and the public, and sometimes by the researchers even, is the decline in cardiovascular disease mortality in the developed countries. So we can look at the trends in selected developed countries I've put up on this slide for male and female cardiovascular disease, and they have gone down by 50 to 75% during 3 to 4 decades. So having observed these trends, we can ask ourselves three major types of questions in epidemiological studies in general. One is, what is the effects of the risk factors on overall disease and loss of health? One is, what is the effectiveness and cost effectiveness potentially of the interventions that we know of for these risk factors? And we also may be interested in the effects of risk factors and their interventions on disparities in health. Do they increase them or to reduce them? I've done some work in my dissertation on the first and third topic, and since then I've moved a little bit toward more effectiveness and of intervention. In this particular talk, I would like to speak about two set of sort of paper research. One is the work that Professor Merson mentioned in the global, regional, and national trends in cardiovascular metabolic risk factors, and secondly, on the interventions of a specific medical intervention for these risk factors using electronic medical records. The first work is part of the Global Burden of Disease project, which is a collaborative effort of several universities and a couple hundred researchers around the world. And the aim of this research in this particular group is to collect as much information that we can on metabolic risk factors of chronic disease and estimate the regional and global trends. So we looked at, and this work, as was mentioned, was published in The Lancet last week. 3 papers, one on systolic blood pressure, one on cholesterol, one on BMI trends, and a 4th paper on blood glucose levels and diabetes is under review. We looked at 3 major types of information. This is probably too detailed. I just want to show that there are published studies, unpublished studies, like government reports that we took from WHO Infobase and other sources. And we also had a sort of different arm which we tried to collect individual level data on surveys, population health surveys that we had access to. So those type of studies we analyzed ourselves. And in the end, we had about 786 country years of data from about 5.4 million participants. So we wanted to collect this information and sort of estimate the levels and trends on blood pressure in this context. Here is the distribution of that data over regions. I have pooled the data over time. They are well spread over time. So we have data from earlier in the 80s, and we have data from the 90s and the 2000s. And what is interesting in these maps is that a lot of data is from actually developing countries. So we have quite a few data sources in China and India and in Brazil, the most populous countries. But nonetheless, 64 countries don't have any data on blood pressure. And those are mostly sub-Saharan African countries, Central Asian countries, and some countries in Latin America. So we have to come up with some way of handling this problem of missing data for these types of countries. 20% of these data sources are from nationally representative health surveys. Another 15% is from subnational surveys, sometimes a region, a province, or a state, something like that. And the rest is community-level surveys. When we look at the 20% national data only, obviously there are far fewer data sources, but still China has more than 4 national health surveys for blood pressure. US and Japan are the best countries for data. Japan has pretty much annual data in the duration of our study. But as I said, we do have a lot of missing data for some of the countries. We have missing data for older ages, and we have incomparability in data sources. So we used a statistical model to deal with these types of missingness and incomparability. And what I mean by incomparability is that about 8% of our data sources were reported papers in the articles published before that had reported hypertension. But our index of interest in the global burden of disease is the distribution of blood pressure. So we want the mean and standard deviation. So we used a regression based on our own survey data to go back from the hypertension prevalence to mean and use that in the model. So we also had missingness for whole countries, and we used a hierarchical Bayesian model with covariates. What the model does is that it assumes that studies are clustered within countries, countries are clustered within regions, regions are clustered within larger regions, and everything is coming from a global prior, so to say. So if there's a country with missing data, if there's another country in the region that determines the mean of that region, that mean is assigned to that country, heuristically say. And if the region is missing, super regions and elsewhere. So that's the hierarchical structure. But the model also includes covariates. And these include food availability data from the FAO, income of the country, urbanization of the country is included in the model as well. So the covariates also inform part of the imputation process when there is no information. For missing data in older ages, we had a flexible nonlinear age model to incorporate that relationship between the age and the level of the blood pressure in various levels. And we had missing data across time, so we have also a smoothing model for time that incorporates that element. As I said, only 20% of this data is from national representative studies, but we want to estimate for national level countries. And one thing that we know of is that sometimes a particular study is conducted in a particular place because the researchers already know that there should be enough very high or low blood pressure levels in that particular community. So we wanted to capture that prior in our analysis, so we added an additional level of bias and variability for community level studies. So they have more noise in them, they jump more, and they sometimes are either systematically higher or systematically lower than the national level studies. So in a nutshell, what our statistical model does is that it borrows information, quote unquote, across age, across time, across space, and across covariates. And what it does in that sort of borrowing is that it propagates the uncertainty through the estimation process. So there's uncertainty in the sampling variability in the studies themselves. Then we have models that we convert the mean to the hypertension prevalence or vice versa. We incorporate that as well. All the sources of uncertainty go through the model, and the final uncertainty incorporates all those elements. So the unit of observation for us here is one country age year. And we estimate the mean of systolic blood pressure for that country, age, and year. So if you look at some of the results in 2008, for men and women, the means are generally higher for men than women. Regions of high-income regions of North America, Australasia, Asia-Pacific high-income countries have very low blood pressure levels in the order of 118 to 120 millimeters of mercury. And regions in sub-Saharan Africa, East and West, and for men, the Baltic areas have levels as high as 135 to 138 millimeters of mercury. So the difference of 20 millimeters of mercury between the highest and lowest, if we accept the results of the prospective studies collaboration, which was the largest sort of collaborative prospective study on blood pressure for 60 to 69-year-olds, this difference translates into twice higher risk of coronary heart disease and 2.5 times higher risk of a stroke. So massive uncertainties between regions. But our model also gives us the trends. I have selected a couple of regions just to show the differences here. High-income regions on the right and developing countries on the left. All high-income regions had a decline. For men here, I'm showing 2.8 millimeters of mercury decline per decade for men in North America, and also declines in other high-income countries. Most populous regions, East Asia and South Asia, had pretty much flat trends in blood pressure, and East Africa, Sub-Saharan Africa, had an increase of 1.6 millimeters of mercury per decade. And I'll also note that I want to attract your attention to how the model is sort of estimating uncertainty, comparing, for example, South Asia back in the 80s. There are not many studies here, so the model is sort of fanning out, versus Western Europe in the 90s. There are many, many studies here, so we have very tight confidence intervals for our estimates in that region at that time. The results in women are generally similar, but a little bit steeper slopes and a little bit more variability, I would say. The best decline is in Australasia, 3.9 millimeters of mercury per decade, and some increase again in East Africa and Oceania, 2.5 to 2.7 millimeters of mercury increase per decade. So having this sort of massive data set of country, year sort of estimates in levels of risk factors, one can ask what are the effects of these risk factors on cardiovascular disease, mortality, or morbidity in every single region. And that's something one can do with different approaches. One approach that was developed by Dr. Izzati and others in the WHO during the 2000s and was used in the later rounds of the global burden of disease was the comparative risk assessment framework. So what this framework does is ask the question of what is the overall effect of this risk factor on disease, and it estimates that effect by shifting the distribution to an optimal distribution. and integrating the risk over that change. So what is the effect of blood pressure if everyone had an optimal blood pressure of, say, 115 millimeters of mercury? That's what was used in that study. So that's one framework, and I use that framework in the context of the U.S. using data from the National Health and Nutrition Examination Survey in 2003 and 2006. The relative risks for this particular study was derived from meta-analysis of epidemiological studies, and the mortality estimates were from National Center for Health Statistics. So for each single risk factors, we have asked ourselves, what is the overall effect of this risk factor on mortality? And it includes cardiovascular disease in the black, which is pretty much most of the attributable mortality, and some cancer and other respiratory diseases, for example, for smoking. So what is striking here is that I just showed a huge decline in blood pressure levels in North America since the 80s, but still high blood pressure is the second leading cause of death in the U.S. in 2005. So there's still a lot to be done in controlling blood pressure level even in this country. And this framework can also be used to estimate trends across time. This is one snapshot in 2005, what one can do time trends. And one can also look at the effects on disparities. So in a different work, we looked at disparities in life expectancy by race and geography. I'm just showing men as an example here, where Asian Americans live by far about 14 years more on average than African Americans in high-risk urban areas in the South. So the question is, how much of this difference in life expectancy do our classic risk factors of cardiovascular disease explain? And again, one can use the comparative risk assessment framework to answer this question. Here, because we wanted to have data by race and geography, we had to use a different survey, which is the behavioral risk factor surveillance system, which is much larger and has geographical information, and what doesn't have measurements because it's a telephone survey. So we had to go back and estimate the levels of the risk factors using models. And we did that for 4 top risk factors: smoking, blood pressure, obesity, and glucose. And we asked ourselves what happens if we move them to the optimal level. So on that figure, I've now put a second set of bars, or third also. But on the red, I have the optimal distribution. These are our distributions corresponding to lowest mortality levels, for example, for blood pressure 115 millimeters of mercury. And what happens is that all of the subgroups in the population gain some years of life in life expectancy, but those who are worse off gain more, and that reduces the gap by about 2 years, and the standard deviation of these, or the variation of these life expectancies, by about 18%. So that's what we got as with a look at the disparities with these risk factors. So both of these set of works looked at the overall effects of risk factors compared to an optimal distribution. But sometimes we are just interested in one particular intervention, and that's where individual level records are more useful. So this is a second paper that I'm presenting today, working on effectiveness of statins to reduce the risk of coronary heart disease in a primary prevention setting. So the aim of this work was to use electronic medical records from UK and improve our methods of comparative effectiveness or effectiveness intervention, which is pretty much in the radar screen of funders and all the people interested in reducing health costs these days. So in this field of comparative effectiveness, randomized clinical trials are usually considered the gold standard. Because by randomization, if it's done successfully, we have no measured or unmeasured confounding at baseline, and we can estimate the effect in the population directly. And we should also note that there are some limitations, which is that we usually select a population that contributes and cooperates with the trial better, so we may not be able to generalize that effect to the population of interest directly. Also, we may use a specific dose or a couple of doses of drug in a factorial design maybe, but the question may come up for a different combination or a different dose, so we may have to redo a trial or do a new trial for that. Sometimes the compliance in the trial population is different or very different from the trial population of interest, so we have to take that into consideration. And sometimes the trials may not be generally feasible because of time or financial reasons. On the other hand, we have observational studies which don't have the limitations of generalizability, but they have a big limitation of confounding in the case of medical interventions, confounding by indication. People do get the treatment because they have higher or lower risk, and that has to be taken into consideration where we are estimating the effects of these interventions, the causal effects, ideally. So the aim of our study was to improve our methods of dealing with confounding in the context of observational studies. And for that particular reason, we chose this context of primary prevention of heart disease with statins because we knew there's a lot of confounding by indication. Statins are indicated for people who are at higher risk of heart disease, and we also chose this context because we knew from about 12 primary prevention trials that there is about 32% reduction in risk of coronary heart disease with statins, with a relatively consistent estimate between these trials. So we chose this data set, which is part of the GPRD network, General Practitioners Research Database in the UK. This one is called the Health Improvement Network. It's just a different company. The database includes demographic characteristics. It includes the levels of the risk factors measured, all the lab tests that they have done, treatments that have been prescribed to different patients. It includes disease history, family history, and also we validated the coronary heart disease cases using medical records review ourselves. The study population is about 600,000 patients in 350 practices in the UK. It's a very general population. It's sort of by distribution of age and gender matches the population of the UK. And we have records from January 2000 to December 2006, about 33 million person months of observations. The aim of the study was to look at this database with the eye of a hypothetical randomized trial. So we take the observational study, the electronic medical records database, and we think of it as conducting an imaginary trial on this population. So we assign an enrollment period, say January 2000 in this case, for example, and we look at the database, everybody who is on the database in January 2000 and matches our eligibility criteria is eligible to join the trial. And then we look at their treatment history. If they happen to be treated, they become the treatment arm, and if they happen to be untreated, they become the non-treatment arm or the control arm. So we call these initiators and non-initiators. They shouldn't have been on treatment before. I'm going to talk about that in a minute. Then end of the January, the trial enrollment is closed, and we can follow them through time until in this study for 7 years and see if they have the outcome or not. Obviously, they are not comparable, and we have to take care of that later on. But there is no reason we have to enroll people in January 2000 only. So we can go in February 2000, conduct a different trial, imaginary trial, March 2000, and so on. So in this manner, we have a series of nested, non-randomized trials that we can create with this population in the context of the electronic medical records. In our case, this was 83 nested trials. On average, each person contributed to 11 trials in this context. So we can mimic this trial's eligibility criteria. So if our imaginary trial enrolls people with 55 to 84, we can mimic. This is a primary prevention trial, so they shouldn't have prior events of CHD and no major other chronic disease. That's usually a standard in clinical trials. Also, they shouldn't be on statins before, so they should be statins naive. We can replicate that. One thing that we cannot replicate well is this history of no subclinical disease. So many trials exclude people with subclinical disease by doing a very sensitive test like an exercise ECG or something else. But our doctors here in the UK do what they do. They may not order that particular test. They may order it for one person or not the other. So I'm going to go back to this point later in the talk and mention some of the methods that can be used to reduce the bias due to this difference. Obviously, our trials are treatment prescriptions, and they're not randomly assigned, so we should take care of that also. But the outcome can be mimicked as well as we can measure the outcomes in the database, and this is a relatively high-quality study. What we want to also do after we mimic the design of the trial is also mimic the analysis of the trial. So the most common analysis done is an intention to treat analysis. So we want to do the same analog of the intention to treat analysis in our observational setting. We want to compare our initiators to non-initiators and have a single effect for the effect of treatment if the effect of treatment overall in the population. The problem with that is that we have some common causes of statin treatment and CHD, so we can use these directed acyclic graphs, which are now commonly used in causal inference literature, to show that there are some things like the LDL levels at baseline, which are used to prescribe statins. Those who are higher LDL levels get higher likelihood of being prescribed statins, and also they increase the risk of CHD, so they are common causes of treatment and outcome, and they have to be adjusted. And there are many, many of these. There is age, there is family history, and we can include, I have just shown LDL as a representative here. So we have to adjust for LDL, but that can be easily done with any statistical method. The standard methods like the Cox proportional hazard method easily takes care of this type of confounding, which is confounding by common causes at baseline. So we do that, and we adjust in a standard model for all the predictors that we think are jointly related to treatment and outcome, and here is our results. So we have about 6,000 cases in 845,000 almost person trials. Our unadjusted hazard ratio, as we expected, is hugely confounded. So it shows that the statins increase the risk of heart disease by about 40%, which is obviously wrong. But our hazard ratio adjusted for all baseline covariates shows 11% reduced risk of heart disease, although it's non-significant. So we managed to get some protective effect of statins in the context of the general population in the UK by mimicking these imaginary trials and adjusting for differences at baseline using a standard statistical methods. So we can just stop there and say this is the effect we estimate. The difference between this 11% and the 32% from the trials that I showed you is either non-compliance, and we can show that non-compliance is indeed higher in this population compared to the average in those trials, or this is residual confounding. There are some things that we don't have a good measure for here in the case of this particular database. It's a medical database, so sometimes, most of the times, it doesn't have data on diet. It doesn't have data on physical activity, and those may be common causes of treatment and CHD outcomes. But one thing we can do, and we can take one more step forward, is that we can ask ourselves, what if everyone had adhered to treatment? So let's ask the question of compliance in the context of these trials, non-randomized trials. And that's of interest because even if you have a real trial, the population of interest when you want to assign the effect to might have a different compliance level. And also when a patient comes to a doctor and asks for an effect of treatment, they might as well be asking for the effect of treatment if they adhere to treatment, not if they don't adhere to treatment. So we sort of started doing some work on the compliance adjustment using this data set. So we wanted to ask, what if everybody had adhered to treatment? So two general suggestions for doing that in the methodological literature. One is called the per protocol analysis, and in the trials literature as well, is per protocol analysis when you censor person time or persons when they go off the initial treatment. So if they were assigned to no treatment, they took up treatment, they are censored, and the same for the treatment arm as well. And we estimate the effect if everyone had adhered to the initial treatment. The other suggestion is do a sort of what we call as treated effect. So you look at the treatment over time, and you assign a sort of one functional form to the treatment. So it can be the cumulative dose of treatment, it can be square of the cumulative dose, average dose, or any functional form that you think biologically is reasonable for that particular treatment. And you fit a model for the effect of the treatment on the outcome in the whole population without any censoring. So just comparing the two, we sort of expect that in per protocol analysis, because you're censoring persons and person times, you have less information and more variability. In the as-treated analysis, you have to make some some modeling assumptions. So your functional form should be a suitable functional form for that treatment in that population. So we did both in the context of this study. And here are the results. So in the per protocol analysis, we have fewer cases. Some of them are censored because they happened after the person discontinued their assigned treatment within the same set of trials. The unadjusted are still confounded, and the adjusted for baseline covariates sort of shows that almost the same effect in the intention to treat, possibly a little bit stronger protective effect. On the as-treated analysis, we use the cumulative dose and cumulative dose squared. So we wanted to relatively flexible functional form. So if somebody is 10 months on treatment, they have a 10 months of treatment and 100 months squared of treatment to take care of non-linear treatment functions. So then when you have to a specific functional form, you have to choose some period of treatment to estimate the effect. So we chose 2 years, which is almost the average duration of treatment among the treated in this population. That's an arbitrary choice, almost. So for the effect of 2 years, we also had about 27% reduction in risk. But the problem with these two estimates is that they are not causally interpretable, because for both per protocol and as-treated analysis, we are looking at treatment after randomization. Randomization is only successful, if successful, can only remove confounding at baseline, but now we are first either censoring people based on their treatment history or using their treatment history in our analysis. And one can show using the same DAG that this creates a sort of complicated confounding situation. So I'm showing the same DAG for a single trial. Previously, I had statin 0 and CHD only, and LDL 0 was here. I've removed LDL 0 because we already decided that that can be taken care of using standard methods. And these DAGs are shown under the null. So there's no effect of statins on CHD. There's no effect of a statin at time 1 on CHD. So if there's no effect, you shouldn't see any association. The association when you see when there's no effect is all bias. So we start by looking at statin 0, and there's no bias because there's no way to go from statin 0. We have already adjusted for those common causes. But the problem is with statin 1, because statin 1, even when there's no effect, is associated with CHD through this pathway, through LDL, through unmeasured factors. And these unmeasured factors could be genes or diet or something that causes LDL and CHD to change, poor diet or physical activity or anything that we don't have data for. So what is usually done in the standard statistical models is that we adjust for this bias or confounding by conditioning on LDL. So we look within levels of LDL, low LDL, mid LDL, high LDL, or some sort of functional form, and we sort of block this path. Once this is one level of LDL, there is no relationship between a statin and CHD under the null, and we are fine. But what happens when we do that is that we make troubles for statin 0 because we have first blocked the effect of statin 0 through LDL1 on CHD by looking within levels of LDL. So part of the effect of statin 0 is now not there, which should be. And the other problem is that we create this path, which goes from statin 1 to statin 0 and LDL1 to CHD. Conditioning on LDL1 opens the association between statin 0 and unmeasured factors. So if I tell you that there is this person with a very low LDL level and he's not on statins, we have some more information about their unmeasured factors. If he's not on statins, then he's probably on a very good diet or has very good genes. So that's the association that is created between statin 0 and unmeasured factors by looking within levels of LDL. And that sort of transfers this bias all the way to CHD. So the standard method that tries to reduce confounding by this factor introduces bias for the previous treatment levels. And there are methods specifically developed for this particular complicated confounding situation which do not work by conditioning. The aim is to use this group of methods, which are generally called the G methods, to remove bias by statin 1 and not introduce bias for previous time points. And a particular example is the inverse probability weighting, which is used in marginal structural models. So here A is the treatment, and L is LDL and all the other confounders. So we weight each observation by the inverse of the probability of the treatment that they actually received. So if they were treated, that's the inverse of probability of being treated. If they were untreated, that's the inverse of the probability of being untreated. And that probability is estimated using a logistic model for treatment, for example. And then we create a new population in which the treatment at further time points, like statin 1, is dissociated from its past. Because we rated by the inverse of that probability, the diagram now looks like this. There is no association between LDL-1 and statin-1. The effect of statin-1 on CHD is unbiased because there's no way to get there. This pathway is blocked because we are not conditioning on LDL anymore. We don't need conditioning on LDL. And the effect of statin 0 is also unbiased. So that's what we are trying to do. And we do this by this sort of complicated weight models. They're not as complicated as they look. This is the same thing on the above, but the numerator only serves to stabilize the weights. It reduces the variance of the weights, and it reduces the variance of the final estimator. The denominator is just the probability of treatment, given past treatment and past covariates, and given that the person is not dead by the time of that you are trying to estimate the effect. Because we are not conditioning on LDL anymore, these are called marginal models and marginal structural models because they work with the counterfactual probabilities of causal effects. So this is how our population looks like now, and we can estimate the joint effects of any treatment and any functional form of treatment because we don't have any so-called time-varying confounding in this context. So that's what we did, and here are the results in the bottom row. So the effects changed a little bit, but not too much, and sometimes in the direction that we didn't want them to. We show 16% reduction in the risk for continuous treatment of statins. If everyone had adhered to treatment, that would be the effect, still non-significant, and maybe 21% for 2 years of use of statins in this context. So these results may look more interesting and more surprising if we do and repeat the analysis which is usually done in the context of observational studies, which is comparing current users of treatment to non-users or never users of treatment. And everything is adjusted for in the same model. There is no model for treatment. There is no inverse probability weighting. You have a model for CHD. It can be a logistic model or a Cox model or any model. And you adjust for everything in the same model and estimate the effect of current use of the statins versus non-use or never use. And that's what we get. So there's no percent trials here. So we have only 600 cases among about 75,000 individuals. Unadjusted is obviously confounded. We had that in our intention to treat analysis as well. But when you adjust for everything that we had adjusted for in that analysis, with the same functional forms, everything is the same, you don't get pretty much any reduction in bias. And that's exactly due to creation of the bias that I showed you in the context of the DAGs, which conditioning on these factors on the way introduces this pathway and creates this bias that's inherent in these effects. So these analyses show that even after adjustment, the statins are harmful for coronary heart disease, which is obviously biased. If you restrict to people without chronic disease at baseline, helps a little bit, but not too much. So some people justify these analyses by saying that these are current users, so this is implicitly adjusting for their adherence. They are on treatment. And they may go even further, saying that let's estimate the effect for longer treatment, more adherence to treatment. So the exposed group in these analyses are current users with at least a year of treatment. So maybe a little bit better, but still age sex-adjusted estimates are better than the multivariate adjusted estimates, which is very odd. So there is some sort of trade-off going on here between trying to adjust for confounding, but then creating bias because of putting variables that are affected by treatment into the model. So we're trying to hit two birds with one stone, and it doesn't work because we don't have any initiation period, or it's not clear what the baseline is. We are just looking at current use, adjusting for anything most recent measurements of all the risk factors that might be related to treatment. One other reason that people have justified these or supported these sorts of analysis is that they say because these current users have survived for at least a year, they probably didn't have subclinical disease. So the issue of subclinical disease comes back to here. And the bias to subclinical disease is especially problematic in these sorts of electronic medical records databases because presumably the doctor had some judgment based on the overall risk factor profile of the patient and a hint that there might be some atherosclerosis going on, and they did some tests or they didn't, and they prescribed a drug, but we don't have that judgment recorded in the database. So those people get a higher treatment, they are at higher risk of disease. The idea here is that they will probably get the disease earlier in the follow-up. So this analysis is excluding those from the exposure group only. But why not just exclude them overall? Exclude everyone that has an event earlier in the follow-up. So that's what's sometimes done in observational data analysis, and that's what we try to mimic here in the intention to treat and the per protocol analysis. So here is our 0.89 that I showed you for the intention to treat. Goes down to about 0.65 after 6 months, excluding the first 6 months of follow-up, and then hovers around that, and the confidence intervals get wider and wider because you're excluding cases from the study. And the per protocol analysis goes down to 0.5. But we feel that these sort of analyses are not well suited, and they have to be defended based on several major assumptions. Because if the hazard ratios change over time, which sometimes do because of changing effect, by excluding early follow-up, you are bound to get a different effect. Even if the statins don't affect heart disease in the first 6 months, and the effect only starts afterwards, by excluding the no effect period in the first 6 months, you get an average hazard ratio for the later follow-up, which is smaller because you're excluding the higher hazard ratios from your average. So the hazard ratio that I'm reporting here is the average hazard ratio after 6 months of the study. On the other side, if the hazard ratios are going up, if you exclude the lower hazard ratios and you get an average of the higher ones, the average goes up by itself. So it's not clear whether we are introducing more bias or reducing bias. A second argument here is that possibly the effect might be, the true effect might be in the first 3 months or 6 months of follow-up. So that's what happened in the case of the hormone replacement studies. The trials showed an increased risk of heart disease in the first 2 years of the study, whereas the observational studies showed a protective effect for the rest because they were looking at survivors who had passed those first 2 years of high risk. So we know for statins this is safe enough because there are many trials that show that statins don't have an early period of hazardous effect and then protective effect. So some sort of these figures might be used to summarize the effects of statins on treatment in the context of observational studies using electronic medical records. So in summary, I showed the study of global and regional trends that showed large declines in systolic blood pressure levels in the developed countries, flat levels in most populous developing countries, and increases in sub-Saharan Africa. There were large variations in trends even within high-income regions, especially for women, when there was trends in and the slopes in Australasia was almost twice as much as higher as North America. We also showed that in the statins analysis, they reduced the risk of new CHT in the UK by about 11%, and if you consider adherence on top of it, adherence treatment with statins may increase the risk to 16 to 21%. Some new directions that this work may take is exploring the associations between different cardiovascular risk factors at the global level. So we have these massive databases on blood pressure and obesity and cholesterol, and one can look at the variations that might be existent between different levels or levels of the risk factors in different regions and sort of sub-models of the epidemiological transition, where obesity might be going up in one region, but not diabetes and cholesterol and vice versa. And some of the potential determinants, if possible. One can look at urbanization as a determinant of obesity or high cholesterol levels or blood pressure levels. If there's data, one can look at the effects of treatment at the population level as well using those databases. One can estimate the effects of these risk factors on mortality and morbidity, which is going to be done as a part of the global burden of disease, but also their role on disparities across nations, within a region, or even subnationally, because we have community-level data as well. One can apply these causal inference methods that I just presented to population-level analysis of risk factors, including time-varying and multiple interventions. I'm currently working with the nutrition department at Harvard School of Public Health on multiple lifestyle interventions for diabetes prevention in the context of nurses' health study, looking at weight loss, smoking cessation, physical activity, overall, how much would they reduce the risk of diabetes, for example. And one can also do a similar analysis that I presented for statins for joint interventions, joint drugs. What if statins and antihypertensives are prescribed together? What if aspirin is added, or other combinations of treatment for different subparts of the population? And also, causal inference methods that I presented for the case of statins can be used to estimate the direct and mediated effects. So there's some discussion going on with the obesity epidemic as to how much can we block the effects of increasing obesity on heart disease by just intervening on blood pressure and cholesterol, and how much of it will be remaining because obesity just directly affects the risk of heart disease. Thank you so much for listening. I want to acknowledge my mentors, Dr. Zati, Dr. Hernan, and my collaborators and colleagues here, and I'm happy to take any questions.
Thanks, that was terrific. I can just shout. Oh, I see. Well, I have to speak very, very carefully then if we're recording it. So, behind some of this work, I see I see Miguel's influence behind this work, especially his editorial in Epidemiology. I think it was 2008. Observational studies analyzed as randomized trials: the best of both worlds ? But Miguel has another relevant editorial, which is the hazards of the hazard ratio. Right, which talks about generally how using hazard ratios can introduce selection bias in a structural sort of way. And that one way to avoid that is cumulative incidence curves adjusted for confounding over time. And, Steve Cole and Miguel have put out code for how to do that. So I didn't see that in the work. Are you publishing that in the SMMR 2011 piece, and why not? I mean, where's that fit in?
Because of page limits. No, we did that. So the macro that's developed to do this analysis is sort of suited to estimate the survival curves or cumulative incidence curves. You can look at any time during follow-up and estimate the absolute risk of the event, compare the treated to non-treated, or any different intervention that you're interested in. So every other month of treatment, or 2 years of treatment versus no. We just did, the piece was getting so long, and it had already 4 different sort of subtopics in it. So we decided to put it as a different piece. So hopefully that will be coming in a separate, piece in the coming months. Yeah, that's the way. So the hazard ratios in that context will serve as a mediator, sort of. We still fit the same proportional hazard model, but we estimate the absolute risk under different scenarios, and we compare the survival curves. That's the way to go. We thought that in this particular case, it didn't quite fit the trends of the paper, and we had to explain many, many more things that we didn't have space for. Great question. Yes.
Yeah, very nice and elegant presentation. A lot of interesting ideas. I have about 50 questions I'd like to ask, but in the interest of time and to discipline myself, I'll stick to one. So a lot of us in the room have done observational treatment comparisons and have struggled with the whole field and how to think about it. And your work really brings up some issues that we've talked about a lot, which is how to define the boundaries of when you should do it and when you should just back away. And so I was worried that you started off with an unadjusted hazard ratio of about 1.7, indicating, roughly speaking, I think, indicating that the patients that got statins were clearly higher risk. And to go from that, and that's including, if you assume that there's some underlying treatment benefit to statins based on extrapolations from other data plus whatever we know from the primary prevention trials, then that's averaged in already. So the real bias is even more severe probably than that. So then you're asking a mathematical model to figure out how to not only wipe that completely clean, but then discern a relatively small treatment signal underneath it. So you're actually going in the opposite, you have to not only cancel out all that, but then go and find a real signal with some math and some data that's, there's no guarantee. So the problem is, how do you know when you should just quit and say this data is too severely damaged to use in this fashion?
Good question, and I don't think I have a good answer for it. So in this particular case, we had a previous sort of systematic review and meta-analysis of all the literature on statins. So the graph I showed you on trials is part of it, and we did a second one for secondary prevention trials, and we compared it to secondary prevention observational studies, which is very actually interesting, because the secondary prevention observational studies start a crude estimate that is more protective than the adjusted and more protective than the trials. So they show 70%, 60% reduction in risk of coronary heart disease, which is what we think is healthy user bias. So when people go to the hospitals, then the ones who have a better potential or better sort of prognosis get on treatment. And many studies have shown that actually those on treatment are usually younger, they don't have coronary heart disease and congestive heart failure. They don't have. So the pattern of bias depends on the context. And I guess going back to your question, when one should just avoid doing it, I guess maybe if you know that the signal, as you mentioned it, which I would call like causal effect, is too small and the confounding is too large, but there's no way of knowing that before doing the study actually. So if some people...
But wouldn't you say that you need to have some criteria set up before you start analyzing to decide when you're going to declare that this thing is irreparably confounded? I mean, you have to set something up in advance. If you only decide after you've finished the analysis, you're already heavily invested in getting the thing published, and walking away at that point is going to be pretty tough.
Yeah. I don't have a good answer for that. I think if you start with a confounding of a level of, say, relative risk of 2 on the other side of the null, and you're looking for 10% reduction, that's pretty much hopeless. In our case, it was 1.45, and then we were looking for 30% reduction, which we ended up finding 11% of it. So it ended up being not very hopeless. But I can see your point that in some contexts with a very small effect and very large confounding, if it's previously found in the studies. In this case, there's only 2 other primary prevention observational studies for statins. So that sort of got us a little bit thinking, why is there 20 secondary prevention observational studies, but only 2 primary prevention? So that's probably publication bias. That's the studies that you mentioned that they start. And those 2 studies one study excluded 30% of cases because they didn't match the controls in a propensity score matching algorithm. And the other one also excluded first 2 years of follow-up. We asked them, what is the effect if you don't exclude 2 years of follow-up? They didn't respond. So we guessed that it was probably on the other side of the null or severely confounded.
You alluded to the large amount of missing data at various levels of the populations. And it always kind of worries me when we start doing all these imputations and stuff, and it always sounds great, but in my mind it's just basically making up the data. So at what level do you say, it's a similar question to Dan, what level do you say, well, there's just too much made-up data here and not enough real data to make this worthwhile? And how do you decide, and do you do some sensitivity analyses or something to decide whether there's too much made-up data or not?
Yeah. In the case of the blood pressure, so the cholesterol data is even less. The best one we had was BMI, which was 900-something person country years of data, about 9 million or maybe. Then was blood pressure, then glucose, the least was cholesterol. Data we impute is sort of, you can think of it as made-up data, but is made up based on some assumptions that we make. So the assumptions in this case is that if you don't have data in Tanzania, you can make an estimate from East Sub-Saharan Africa in general. The mean of the East Sub-Saharan Africa could be coming from Angola or other countries in that region. That's one assumption. If you don't have data from the region, we think that it should be close to countries with income like Tanzania. That's the other assumption. Or if you don't have data for Tanzanian 60-year-olds, but you have something for 50-year-olds, we think that you can fit a model for age. We know that blood pressure increases with age, and more so if the mean is higher. So we put those assumptions in the model, and then our model sort of works. So for us, it's not that much of a black box. We make the assumptions that we think is reasonable, and then we look at the posterior of the model to see whether in the countries we had data for, the model is estimating the effects correctly. So one thing that we do in that context is sort of a cross-validation. We sort of mask some of the data. We say 10% of the data, we mask it. We say, assume we don't have this, estimate it for us. Then we compare it to what we have. And I should have a table here that shows the results of that sort of cross-validation. It's a little bit hard to read probably, but so the bottom line in this exercise is this number: 94% of the time, the confidence interval of the model includes the point estimate that we are sort of masking from the model. So we think that on average it does well. Some of the times, sort of, for example, if you look at subnational studies, that's the worst performance. 79% of the data is covered by the model. So some of it, so presumably there's something about subnational studies that we didn't capture. They might be a little bit higher or lower depending on the region or something like that.
Well, thank you very much.
Thank you.